history and that. Um, maybe it'd be 3 or 4 things coming up. But
Mhm.
what I find difficult is I usually like treat those 4 things, whereas I should be really finding the one, that kind of way. That's where I actually find a little bit of difficulty.
Yeah. So, I, yeah, I think I understand what you're saying. So you're saying, well, no, I don't just find one finding and treat it
Yeah.
and then move on to the next. Yeah, I mean that's definitely that method of working is definitely for the so-called beginner. In other words, I've just learned a style and I'm just experimenting to get some capacity, get my hands wet, sort of thing, or my feet wet, whatever the expression is. But so what you're right that so you palpated the whole abdomen and now you have 4 ideas of
Yeah.
what would be useful for the person. And I think to beat oneself up and say there has to be one winner here. And if there isn't, something's wrong with me. That is not what I'm saying at all. I'm saying if you find one winner, actually, I'm saying actually the opposite in a way. I'm saying even if you find the one winner that clears the whole abdomen and looks fabulous, go ahead and do the other 3 if they proved useful. And then what does it mean proved useful? To what extent? So obviously, if you found the one that knocks everything down, that's clearly useful. In comparison, the other 2 or 3 are not likely to be quite as useful. They're going to be doing well for some less findings than the big one, and maybe not as much, but they're still worth employing because what looks on the table like this is the joker, this really cuts through everything and does the whole thing. 2 hours later can prove to be totally not the thing. All the symptoms come back. It was a temporary band-aid. But on the table, you can't tell the difference between a temporary band-aid and the true solution. Because the way I'm evaluating is if it clears the findings, it's supposed to be doing something good in the body. That's my way of evaluating it. I can't guarantee how long it will last. That's why it's better to attack it from different positions. I, I used to have a teacher in school. This is a long 30 years ago. Robert Johns used to like to say how, you know, in a in a James Bond movie, you have James Bond with his little suitcase, and and the car, the fancy car, and he is against the world, and he alone manages to bring down the evil empire. In a kung fu movie, you have like a million little guys, like all doing ha ha ha, whatever. And it's not really so much about the one central figure. It's about you need many strategies. And he said acupuncture is like that. You have to have many strategies. Or like it's more obvious with herbs because with herbs the Chinese never don't really like one herb formulas. So they have, there's a king of the formula and the assistants and the ones that convey the message and stuff like that. So you have many, there's 4 different roles for herbs that can take. You know, so it's not about James Bond. It's about what does the formula do as a whole. So to try and say, yeah, I palpated the whole abdomen. I came up with one idea and I implemented it and it knocked down everything is a little bit dangerous also because you're not taking any insurance at all. You're just too sure of yourself. So that's why I'm saying you have 4 ideas from the abdomen and the medical history. You're going to prioritize it in accordance to the medical history. Or it won't be the ultimate judge, but you're correlating and prioritizing, you're making up a story, then you're testing the story and you're saying each story, how much good does each story, how each correlation does for me. Some of these correlations you're going to say useless and you let them go. Some of the correlations you say, well, that's pretty good. And some you'll say, wow, this is really good. So you pick the ones that say answer whatever percentage your threshold is for that patient. And it's totally okay. In fact, I recommend using 2 or 3. If you're starting to go after 5 or 6, that becomes a problem. It means I'm not sure what I'm doing. You know, I'm chasing after 5 or 6 different so-called routes. Yes, can it happen? Yes, absolutely it can. But it makes me very unconcentrated at that point. So I'm sort of saying to myself, chances are I didn't get it. And it's kind of weird because sometimes you did get it. You know, there is nothing in the theory that's going to win over what the patient says. It really doesn't matter. You know, so you can do things like you can check one finding at a time and clear it, you know, which I can say, oh, that's bad, that's primitive, you're missing the opportunity, you're blah 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 blah, and the patient gets better. Who the hell cares? You know, so there's really not much else except, you know, all that matters is the patient's response. And the only thing that um, I'm suggesting is that sometimes people forget the big mistake that I see is that people are not as good, um, they're not on top of the medical history as much as they should be. And I think that's the fault of our training. None of us were trained um, like the Western people are to take medical history. We sort of do it because it's supposed to make us look good. You know, we're supposed, you know, it says somewhere that you're supposed to take medical history. It's like a bureaucratical step for most acupuncturists. And what I'm saying is actually it's your most essential step, because without the medical history, you're trying to look at something in the present without knowing what might have contributed. How did it get here? And if you notice in TCM, okay, they're actually encouraging it in a sense, because they're saying, well, first of all, they're saying it doesn't matter what the disease is named Western-wise. In other words, we don't want to know. We treat Chinese. And then they say, well, so we treat Chinese, we take the pulse, we look at the tongue, we ask the 10 questions, we come with a diagnosis, and we say you have spleen dampness, whatever. The problem is that's a pattern. You know, that when TCM names a pattern, that is not the root of the disease. It might be. The root of the disease might actually be, when I was 7 years old, I had worms. I don't know, I'm making stuff up, but you know, that's the root. The root is not you now have a pattern that sounds holistic. That's fair enough. But that's not the root necessarily. And in fact, if you look classically, you know, if you look at the, you know, Suen chapter 1, it asks what are the roots of disease? You know, that's the, you know, people used to live longer, you know, or whatever the, you know, the 7 and 8 cycles. You know, I have to look it up again to make sure, but emotional factors are the roots of disease. They come from our internal landscape primarily. And yes, by the way, there's also things like, you know, snake bites, whatever. But it's primarily, it's the lifestyle and our emotional um, outlook. You know, so it's things like, oh, they were drink, you know, nowadays people drink too much, they go to bed too late, they work too much, they have too much sex, they don't rest enough, you know, whatever it is that they say. It's all about lifestyle. They're looking, the root of disease is not the named pattern. So we've been trained to some extent with this ideology that if I can see the pattern, which I can without the medical history, yes, you can see the pattern. Absolutely. From a TCM perspective, yes. And therefore I can treat it, because that's the way we were trained, that you see that, you know, there was a very strong component of, it doesn't matter what the person says or you know, the symptom is named, treat a Chinese pattern. You know, and if you're treating the Chinese pattern, you will know what to do. That will dictate what needs to be done. Which is, by the way, kind of absurd, because if you look at all the case studies that come from China, you often see that they do exactly what they tell us in school. And then when you look at the treatment, you go, there is very little matching between your diagnosis and principle of treatment, and it's usually herbs. And you go, where did all these herbs come from? They came from the symptoms. They had very little to do with it, with the so-called diagnosis often, you know. So, but we've been told that, so we've been told that the medical history is not important in essence, even though we were never told that outright. The message was constantly. So what I'm seeing constantly, people email me and ask about cases. And when I ask about the medical history, the most common response is, I don't know, I don't remember, I never asked, or I don't remember or didn't ask are the common ones. And it's always like, okay, you know, you if you don't know the medical history, it's going to be so much harder for you to find a treatment, because then you're only relying on abdominal palpation. And that's, in my opinion, it's like driving blind, or at least with heavy sunglasses on or something, because it's just, why not get the full view? You know what, you know, so it just gets a little bit too narrowed by not including the medical diagnosis and looking at it. And all it takes is ask the patient to fill it out. It takes the patient 5 minutes, but you know what? It doesn't matter to me how long it takes the patient. Let them do it at home.
Yeah.
Do it on paper. Don't, you can ask them questions about it. Never, my experience honestly is, if I talk to them about the medical history, if I ask them to tell me, it will take forever and it will be confusing. It's best to have it on a piece of paper first, then you can talk about it. Because once you start talking without having the whole outline in advance, they're going to get drawn to other things. You're going to get drawn to other things. It's going to get very confusing. So I really like having it on a piece of paper. And then I use that. That's kind of like my Bible for the patient, for me.
Yeah.
So,
Oh, yeah, I do agree. I think it's nice, you know, it's very helpful to have a, and I did copy your form, which makes it very, you know, chronological order. It's nice, you know, and it does point you often
right.
in the right direction. Yeah.
Yeah. And then if you want something, I don't use them, but you know, those sheets where you circle my systems, you know, a lot of people use intake forms that, you know, give you
Yeah. So,
digestive disorders all in one, and
yeah.
you
Yeah.
check or circle whichever one applies, and, you know,
Yeah.
ocular diseases, whatever. Um, that often, you know, if you just look at it, even though you don't know the age, it doesn't matter, but you're going to go, oh, they have this, 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 that. It's a very quick way of just seeing systems of part of the body, and then it influences how you think. I'm just not trained to do that. I've never trained myself because I've never used that kind of form, but I know people do use them, and I can see that it can be very helpful.
Yeah.
So it's all a question of, you know, how do I train myself to get the information?
Yeah. We were given that kind of form in college because we had
Of
actually
course.
a Western doctor actually
Oh,
uh, doing anatomy and that.
mhm.
And it was like that, you know, digestive, respiratory, and whatever, cardiovascular, and that. But what I found was, you know, it was great. Okay, you got it all filled out, but then it didn't relate back to the Chinese system of treatment, really. You know, actually,
That's,
this system works better. You know.
yeah. I mean, because in this system, I am looking for the Western words.
Yeah.
In the Chinese system, it's kind of like, okay, so, you know, I see that you have yak itis, and well, is that
Yes.
I can't translate it to anything, and
Mm.
that's okay. But you know, it's still, you know, the thing is, it's still, people have digestive. I mean, you know, some systems translate a lot better than others. You know,
Yeah.
if somebody clearly had respiratory problems or definitely had digestive problems, I mean, we stick them in the spleen category or in the lung category, whether, you know, no matter what, you know, because it's obvious. But you would have gotten that from the 10 questions, so it kind of doesn't matter. But yeah, when it gets into like, well, they had an operation to remove a polyp in, well, let's make it internal medicine, so it should supposedly relate. They had polyps in the rectum or the uterus or something like that. They got removed, fibroids or something like that. That does not translate to any pattern in Chinese medicine.
Yeah.
that I can say. It's not like, oh, you know, I had anorexia, and you go, okay, yeah, you're probably spleen, or there should be at least some spleen and maybe some Shen or whatever. It gives you automatic stuff to think about. A lot of the stuff, the Western stuff doesn't, but it doesn't, it doesn't mean that it's not useful.
This is a very pessimistic view of Chinese medicine, I have to tell you, because
okay,
the theory and diagnosis teacher in the room has to
yes.
speak up.
Fair enough. Go for it.
Because I'll tell you, I've had hundreds of patients who have said some version of, oh my God, I've never had somebody ask me so many questions as you.
Mm-hmm.
They don't have Western doctors who ask them, like, what shade of red is your menstrual blood? Or, I mean, the kinds of questions that we ask are really, really different. And I think with the new wave of kids coming up, and I will call them kids because they're my kids, um, they're getting more and more into Western medicine, functional medicine, because they do recognize that Chinese medicine isn't complete, isn't complete for the modern world. And so they really, really are taking both on a really deep level. The functional medicine tests are much more in depth than just the standard of care AMA tests. And I think they really are delving deeply in both the Western side and the Chinese side, and trying their best to find an integration between the two. Now, I agree with you that they do a lot of fancy diagnosis, and then they still end up with four gates, way too much. But I also, you do have people following Kiko and Master Dong and Jeffrey, and trying to really delve a little bit more deeply. So I have to say, I do not share your pessimistic view of things. I think we go way more in depth than Western doctors do. They don't even touch people anymore. I mean, I'm amazed at how many people are recommended for surgery, and it's like, did the doctor even do a physical examination and touch you before they recommended surgery? Oh no, they just looked at the images, and that was it.
Yeah.
So I want to stand up for our profession a little bit in this conversation.
Fair enough. So just to say this, I didn't think I was I wasn't trying to be pessimistic. I might have been critical, but I wasn't, and I was actually, my critique was about, sorry, I know you taught in a school, so it's a little bit unfair, but my critique is more about the schooling system than the people. In other words, I'm not saying these are bad acupuncturists, or, because the truth is, listen, people can do I know people who do, probably the whole vocabulary is 4-gate, stomach 36, and spleen 6, and the occasional P6. And they're great. They do great, so there's clear, it's, I'm not judging what people do clinically speaking. I'm simply saying that there is a phenomenon where most people, and by the way, that includes a lot of the functional medicine people too, they don't look that, in my experience, not as a patient, but in my experience in talking to colleagues, and ask, when they ask me questions about a case, and I ask, so in the medical history, what is there, blah blah blah, and they say, I don't know, I don't remember, I don't this, I need to ask. It's actually because I think functional medicine actually also has a little bit of that, I'm not sure how to call it so that it doesn't sound pessimistic. There's a flaw, in a sense, that we think, and functional medicine says, look, we can have these tests, and we can, if these tests are like this is what we know the biomedical route is. So therefore, these are the supplements, or this is the treatment idea. And all I'm saying is that if you correlate that better with a medical history also, which is
Mhm.
often not complete, you get better results no matter which system
Absolutely.
you're in. That's
That I
really all
agree.
I'm trying to say. I'm really not trying to say, and yes, I am. Look, I'm critical of the education I got. Okay, I will be very clear about it. And in fact, I mean, but I was trained at, over 3 decades ago, and it was quite the zoo. And that would actually be an insult to the zoos. So I won't go there. I mean, I had some good teachers,
Well, and
luckily.
it's true because back in 1995, I took classes with this guy. I think his name was Avi Magadoff, and yeah, he taught me a lot about taking a medical history. So maybe I was influenced by that.
No, that's great. No, and things are changing, and you were teaching at five branches, and that influenced people, and there's many people in five branches that as a result from studying with you, looked further and are looking into functional medicine as another form of doing things. And things are progressing. I don't want to make it sound like everything in the profession is wrong, because I will say also there are many people who, let's say, came from school with me or whatever, but did exactly what the school, are working according to what I was taught in school, which I'm doesn't match what I can do. And they do very well. They're good practitioners. Some of them are terrible practitioners, but some of them are incredibly good practitioners. But that exists in any sort of style. So it's not. It's just saying that it's hard for people when they want to do this style. It's hard for them to gravitate towards taking a good medical history, because it doesn't come naturally to us. That's the main thrust of what I'm saying. So because we haven't been well trained in it, and we were never taught that it's like really essential, I mean, we were taught to do it, but we weren't really, it wasn't emphasized enough. It's not as comfortable. And anything that's not comfortable, we're gonna let go of, if we at all can. So we don't have as good a habit as we should, in my opinion, in taking medical history for this style of acupuncture. It can work great for other styles. For example, I don't think I've ever heard Richard Tan ask somebody what their medical history is. It mattered to him. It's like, balance, yin yang, top and bottom, right and left. I'm making too much fun of it. It's not fair. Um, but Richard Tan had a very particular way of seeing things. You know, for his way of seeing things, medical history didn't really matter. Although I understand that later
That's
he
true,
was,
definitely.
well, that he was into I Ching and astrology and stuff. So, maybe it wasn't medical history, but it was birth history suddenly became important. Um, so different styles work, by personality. The same thing when I went to school, when you talk about the doctors don't touch. So I remember, I went to school in 1990. So there was a lot of fuss made about, we touch people, we the acupuncturists, we touch people, and the Western people, whether it's the nurses or the doctors or the PAs or whatever, don't touch them. And I actually went to the clinicians who were in my school, and I said, I'm having a problem here, which is, you're saying we as acupuncturists touch people, but that's not what I'm seeing. Are you working differently in your clinic? Are you doing something different here in the school clinic than you're doing in your own clinic? And they looked at me like I was crazy. And no, like, no, we do exactly. That sounds like, well, so you're talking about touching, but I don't see anybody touching. And in fact, there was even a little bit of almost pride that people should be able to, you can spot the correct stomach 36 by looking. We barely, you touched people, you took the pulse. And that was one of the things that was really attractive to me about Kiko, is because people basically went and attacked people touching them. There wasn't like, I'll touch you through like far away, through a silk thread and get your pulse. It was like, I'm right on top of your damn abdomen and I'm like really poking around and I'm making it meaningful. It was like, wow. I mean, the contrast was incredible for me. So I don't know what acupuncture schools are like now. For about a year or maybe a teeny bit longer, I was teaching at ACTCM. That was 15 years ago. And, there were changes, definitely, but not, people were still palpating or asking medical history was definitely difficult for students. It didn't come naturally. So one just has to accept that every style has advantages and disadvantages, and that when you come from one style to another, if you say, wow, this style is very effective, I want to understand it, I want to learn it, whether it's functional medicine or whether it's TAN or whether it's this, you're going to come with a certain amount of baggage, habits that are not going to lend themselves so easily to being implemented. Does that make sense?
Yeah.
Yes, it does make sense. I had to unmute myself. Sorry.
No, it's okay. And have a sip of tea also. So, all right. Anything else outside of medical discussions? I can see myself digging myself in deeper and deeper.
Mary Jo?
I didn't have a lot, Evie, actually, but maybe Camille, I might refer back to something you mentioned a few weeks ago, and I meant to get back, and I had forgot it during the session. The piriformis releasing point we were talking about at the time, and I mean, we were told that the gallbladder 30 was the piriformis releasing point at college anyway, but you were talking about something else, and I meant to go back and ask. It was in a different position.
Well, I mean, Kiko has a specific point for the piriformis, but to be honest, I like to just needle right into it. And if you look at where it attaches, if you look at an anatomical diagram as to where it attaches right at the SI joint, I like to go into the SI joint there. Kiko talks about the gumminess, but I also like to just find the muscle and I need to take a needle at least 50 millimeters or longer and just go right into it. Then you can also access it through the Baliao. And then the other thing that's really important is to go to the iliac crest, and you want to actually go behind the iliac crest and then needle downward, and then you'll get a nice release of the piriformis there as well.
Okay.
Sorry, when you say behind the iliac crest, that's a little bit odd. So you talk about the iliac crest in the back.
So meaning that you're actually going behind the bone, because that's what's difficult about the piriformis, is that it really doesn't exhibit itself superficially very much. So that's why chiropractors and massage therapists have such a hard time with it, and why acupuncturists are so brilliant at it, is because we can go behind the pelvic bone. I mean, we could go behind the iliac bone rather, and really actually release into it. And I will tell people that it is the most aggressive needle I will probably ever do on them, because when it is in spasm, you do have to go. I don't use a Japanese needle. I still use a serin, but I'll use a thicker serin, a thicker and longer serin, and I'll go behind the sacrum, behind the ilium, and I'll needle right into it, and I will get immediate results. I mean, I've had people who like could barely walk for 10 years, and in you know, and in one treatment they're 80% better, and by the second treatment it's permanently gone.
Okay, so let me just be clear about, because behind the ilium, okay, suggests that, you know, because I'm assuming that the patient's lying face down at this point. So the
Well, I
behind
tend to do it. I don't actually. I just about never treat anyone face down. Honestly,
so they're on the side.
when I do a back treatment, I do it laying on the side,
Okay.
especially if it's a pain patient, because when they're laying on their side, then I can do a little bit of movement on them
Mhm.
in a way that's dynamic. Like if they're laying face down, there's no movement.
Yeah, it's a dead weight, yeah. But okay, so they're on their side. So the only thing is behind the iliac crest sounds like you're basically just above the buttocks.
Well, okay, so let me put it this way. When I say behind, what I really mean is anterior.
You know, okay, so it's you're trying to, so are you coming from saying, this is my imagination. Are you trying to basically say, I'm coming out of Yao Yan, the lumbar eye, and putting the needle in, and then threading it into in front. So I'm going down into the pelvic cavity from above the
Yes,
iliac crest.
when I say yes, so you're going anterior to the bone. So in other
Oh,
words, you're going where your
thank you.
hands can't reach.
Okay, yeah, that's a slightly, because behind, you know, behind and anterior are opposite terms.
Right. Well,
That's why
it's
I was like,
because
what is this
you're
behind?
needling into the back. So yes, so everything reverses. So essentially, yes, I'm going in by Yao Yan, and then I'm
Threading
angling my
downwards.
needle to go anterior to the bone, and um then inferior.
Right. So basically towards the pubic bone.
Right. Sure.
Okay, got you. So yeah, okay. Yeah, wow.
Well, I
That's
mean, the pubic bone, that gives the impression that I'm going all the way
well, no, but
anterior,
it's the
and
direction.
it's really much more inferior than anterior. I'm not. Yeah.
Yeah, no, listen, I mean, to get to the pubic bone, you would need a 6-inch needle or 7-inch needle. It's not so
Yeah.
simple.
No,
I don't think any
no,
of
no,
us
no,
have
no. But
those.
I'm even just talking about the angle, is that I'm only going in anterior as far as I need to go to get in front of the
Bone.
iliac,
Yeah, yeah,
the ilium, and then really most of my direction is inferior.
got you. Fair enough. Okay, yeah, that's yeah. So it's interesting
Whereas if
because
I'm going into Baliao, or if I'm going into the SI joint, then most of my angling is really going lateral.
mhm. Oh, okay. Oh, because you're trying to get the muscle itself as opposed to just the,
I am absolutely getting this is a very localized treatment, but it is essential and brilliant.
okay. So
I mean, with all respect to Kiko
no,
and
no, it's
releasing and
no,
blah blah
no,
blah, nothing. I mean, nothing works quite like this.
yeah,
And I mean,
yeah.
yeah, I've literally had people who have had pain for years and years, could barely walk, and in 10 minutes they're better.
Mhm. So when you're saying, okay, so again about this iliac point, so you're going from Yao Yan, you know, just outside the large intestine chute, you're actually going from the posterior iliac crest. You're putting the needles, because the thing is, if you want to get the piriformis, you actually do want to be behind on the posterior side of the iliac crest, because the piriformis, I'm trying to imagine it, the piriformis doesn't go in front of the iliac. In my opinion, it stays behind it. You know, in the front you have the abdominal cavity.
I thought the piriformis was more, um, the back of the gluteus.
Yeah, it goes from the sacrum and attaches on the whatever the femur is called, the side of the femur, the greater trochanter, I
Okay.
believe.
Yeah,
Is that correct?
that's what I.
I'm trying to pull up a picture for us.
Great. Oh, yeah,
Okay.
wait a second. It might be easier for me to do it because I'm on a computer. So let me find
Okay,
it.
fine. Yeah, okay.
Piriformis muscle. Here we are. And I guess I should say anatomy. Piriformis stretch. It came
Well,
up.
also if you just do images, it'll come.
Yeah, I will.
Yeah.
I'm sorry. This will take a moment. And images. Okay, I think this might work. Teeny bit on the small side, but let's see if it will work. Let me share that. Share, okay, share this. Okay, so can you see that? So yeah, so it goes to the from the lower part of the sacrum
Mm,
to the greater trochanter.
yeah.
And so
So the
Camille, what
bottom-
you're sorry?
So you can see that I'll get it from the Baliao that's near them and go laterally. I'll
outwards,
go
yeah.
along the SI joint.
Yes,
But
yes.
then you actually can, if you get a longer needle, you can go from the iliac crest.
Right, but
From
in my opinion, what you're getting primarily at that point, because you'll need like to actually touch the piriformis from, okay, so can you see the cursor?
Yep.
Okay, so you're coming from here
Right.
and you're going down to here.
Yep.
That to me is a good 4-inch physical distance. So my suggestion is that what you're actually getting is the glute medius and minimus.
Well,
And that
okay, but
probably resolves spasm. No, I think it makes
yeah,
sense.
maybe that's true. Maybe that's true.
But it just sounds to
And
me.
it's helpful. And it's helpful.
Yeah,
Maybe it
no,
is
no,
true.
because they're stable, and I think the reason is because they're stabilizers, so they allow the piriform. You know, if you're doing both things, you're taking this what you can out of the spasms in the piriformis, which again, because if you're doing it at gallbladder 30, which is here, where they conveniently put the end of the of the black arrow on. So if you're doing it here, you have the whole damn glute maximus to go through. You know, I mean, it's not so simple
Mm-hmm.
to actually touch it. Whereas if you're coming from here, from the sacroiliac area, you're getting a much more exposed area of the piriformis.
Right.
So
Right.
it makes sense. But coming from here, I think what you're really doing is you're taking any associated problems in the stabilizers in the glute medius and minimus
Mm-hmm.
to allow the piriformis to release.
Yep.
And I think that would be my suggestion on that also, is that piriformis syndrome, you know, the piriformis issues
Mm-hmm.
are often not as it's not just the piriformis, it's the stabilization around it.
Yes, and if you put the photo up, I'll also make another comment that it's also
Yes.
very helpful to needle around the trochanter, and you can see from that photo exactly why.
Yes, because it's the other
Because
attachment.
there are a lot of small muscles attaching to the trochanter, so that's also a very important piece. And then what I will do is I'll create mobilization um, um, between the leg and the whole iliac area, and that's why I like to have them on their side when I'm doing it.
Makes sense.
Because I work until that whole area is completely mobilized.
Yeah.
And I'll make sure you get rotation in the ball and socket. So then I turn them on their backs and I get rotation in the ball and socket. I mean, I get everything, you know, acting independently, and you know, that's it. It's usually a quite long lasting, if not permanent fix.
Cool. Thank you.
Yeah, sure.
And Camille, sorry, can I just ask there, like if you were getting it from the point.
Baliao.
Yeah, would that be like S two-ish? You'd kind of needle in there. Is it in through the? How do you?
I use 50 millimeter blue serums usually. That's enough for most people unless they're obese.
Okay, so you'd be, but accessing it from the low points. How do you do it on the sacrum towards the piriformis?
Yeah, needling
Um,
outwards as opposed to inwards. You're not trying to get into the hole. You're trying to get into the.
well, no. I am
Oh,
trying to get into the hole. So
and you're
with
not in the
those,
hole.
there is a certain amount of lateral, but it's probably with that one, I'd have to say it's more perpendicular than lateral.
Okay.
Because if you're
So
actually
at that
on,
point, I am getting other muscles, and maybe I haven't articulated it well. I'm just sort of, I mean, I think after all these years, it's just so automatic for me. So I apologize if I haven't articulated it well or in an anatomically precise way.
okay,
No, that's no problem. It's just I was a bit confused about how you accessed it.
Yeah,
On the
no,
implanters.
I think I would say that the SI joint is more lateral, but the Baliao is more perpendicular.
okay,
And that and then what I'm doing is I'm really getting some of the muscles sort of, that are kind of stabilizing the lower part of the spine, the lower area of the cauda equina, that kind of thing. So, and then the other piece that's very important is to get UB36, to get the whole coccyx moving.
Mhm.
So you absolutely have to check on that.
Yeah.
Thank you.
Mm-hmm.
All right.
And then the other area that often needs to be done. I'm sorry, did I say UB36? I meant UB35, but
That's what I
UB36 is the
assumed you
other.
meant.
Yeah, the getting the UB36 area is really important too, because that's another point that, or another area that really locks the whole process up.
Mhm.
But if you hit those high points, you'll get them all moving. But I also honestly, I do some pretty strong body work around all of this too. I mean, I will grab onto their leg and just really start, rotating their leg, tractioning their leg. I mean, I make sure that the hip is moving in every way, because otherwise every single time they take a step, they're going to jerk their spine and their head around, their skull. I mean, I've seen people have headaches because of this. Honestly, I have headaches because of this.
Interesting.
Because for me, I had a coccyx injury, and sometimes it locks up, and it will lock up my entire spine. My whole spine will rotate towards one side, and I get migraines on that side when that happens.
Yeah. Thank you.
Okay, thanks, Camille.
Absolutely. If you ever need someone to practice on, I'll volunteer.
and make sure you yank her leg, on Zoom when you do the telemedicine.
Oh, thank you for that image, Anavi. Yes, thank you. That's lovely. Yeah.
Unfortunately, some of these things are a little harder to do now, aren't they? So, all right. Anything else before we end?
Anything else, Mary Jo?
No, nothing urgent, Camille, for me.
All right. Well.